Hello. How Justin? How's it going?
Good. How are you?
Doing good. Feeling better?
Yeah, feeling much better.
I'm done with the flu or something, or
Stomach bug, small children. You'll see one of these days.
I was a teacher, so I remember like at the beginning I would get sick a lot at the beginning, so
Yeah, I
yeah.
wasn't sick, and I didn't think I was gonna get sick, and then our baby got sick, and then a couple days later, my son got sick, and I was handling his vomit. So I think honestly that did it. Did it to me.
Yeah. Oh. Well, I'm glad you're feeling better and hopefully everybody else is too.
Yeah, we're making it now. We're getting better. How's everybody else doing?
Good.
Yeah, good. Well, good.
Good. I've told everybody this. I have the anatomy scan tomorrow, so looking forward to
That's
it.
exciting. Yeah.
Yeah. Yeah, I can't believe it's already halfway through. The other day, my husband was like, "Oh my gosh, it's pregnant. The pregnancy's going by so fast." And I'm like, "Speak for yourself."
Yeah. Yeah, we tend to say those things. It's not so
Yeah.
bad.
Yeah. No,
Uh,
couldn't do it. We couldn't do it without them. So,
yeah, I guess takes both parties.
oh,
You.
absolutely. Everyone.
Literally, and yeah, in so many ways. So that's funny. Um, okay, let's see. We actually don't have a lot of people coming in today. Let's see. There's Ashley. Hey Ashley, how's it going?
Amazing. I was sitting here working away and I was like, oh, it's two after. Like, what happened?
No problem. I just gotta honestly three people jumping in today, so I'm just gonna bring them in. Smaller crowd. I'm not gonna let your note taker in, Lisa,
That's totally fine.
but I won't
I need
report it to Zoom. Okay.
I need to figure out how to like not, I don't know, not put it in there.
I have it at mine.
Yeah.
Like mine always says like join meeting, and I put
Yeah.
like it so it doesn't join.
Okay. Yeah. I gotta pay more attention for that.
Well, only a few of you today for the hormone happy hour. So I had a topic I would cover, I'm going to cover, but I wanted to see, since it's such a small group, if anybody has any specific questions for us as a collective while we're here. I know it's probably lunch hour for a lot of people, and you may not be able to unmute yourself, but if you would like to unmute yourself, or you have the capability to, you're more than welcome to ask us some questions. I'm gonna stop there for a minute, and then I'm gonna pull up my slides that I'm gonna go over today for the call. All right. Well, I'm gonna share this, and maybe we could just really do this as like an educational piece. Can everybody see my screen okay here? Okay. And Lisa, I know that you have some personal experience with Hashimoto's, and then all of you have worked with clients with Hashimoto's. So I wanted to go a little bit in depth on just like thyroid hormone and kind of walk through this little PDF that I had put together with the help of Canva and run through autoimmunity and then some of like the things with thyroid, more specifically like how and where thyroid's made and potentially how different systems can interact and disrupt that. Um, so, an introduction to Hashimoto's. The first thing I'll say before, like, just reading from the prompter, a lot of clients here don't realize that they have Hashimoto's or have never been tested for it. And that's something I at least meet one woman every single month who says, "No, I don't have Hashimoto's. No one's ever seen that or checked that for me, or I don't have I don't really know what you're talking about." And the thyroid antibodies are something that's rarely ever tested. So I will say the most important part with any type of um, issue going on internally is actually testing. So I wanted to start with that. So understanding autoimmune thyroid disorders. So Hashimoto's is an autoimmune condition that leads to inflammation of the thyroid gland, and then eventually causing downregulations of thyroid hormone. I think there's a caveat to that. I've actually met some women and men who may not have clinical diagnosis of low T4 or T3, but have all the symptoms associated with Hashimoto's and may have elevations in antibodies. So I would say a lot of times the hypothyroidism and lab markers are present, but I would say like 95% of the time, symptoms are there. And those symptoms are going to vary from person to person. Yeah, and then the process often goes unnoticed until symptoms arise significantly. What I mean by that is, I think a lot of times um, as we age, our immune function with stress and kids and all these other things, um, it takes a bigger hit over time, and you may have had low grade autoimmunity for a period of time, and then eventually it just all kind of piles on you. That's the conversation I hear with so many women here is, the past year has just been crazy. I feel like everything kind of hit me at once, and I don't know where it's coming from, but a lot of these things kind of stew, if you will, and sit there, and then at the with enough stress over time, you may start to experience those symptoms really manifest. So prevalence, unfortunately, women are going to have the higher rate of Hashimoto's than men. Men do have Hashimoto's. I do see it occasionally, but I do see it more in women. This is, I grabbed some of this from an article. I don't know if exactly 1 in 8, but I would say 80% of all autoimmune disorders are women. So Hashimoto's is a piece of that. And then um, looking at other things that I personally think can influence that is women are the only ones taking human birth control. And I also see that kind of bleeding in and causing some autoimmune issues. So prevalence in women's and triggers that I see a lot of that. One, genetics. Obviously, I think there's a hereditary component with all disease subtypes. And, but kind of getting more specific, estrogen dominance does not help the situation. Gut issues do not help the situation. Chronic stress, exposure to environmental toxins, all of these things can heighten your autoimmune response. So, like I just said initially, you may have had low grade autoimmunity. Then you start factoring in these other things over the course of 20, 30 years, and then you may have some serious implications with your thyroid gland. Oh, let me see. Um, Hashimoto's, a lot of times you could have potentially normal labs if you're doing general like TSH and maybe a T4. That's the thing I see quite a bit. Now, if you do have a practitioner who will do a full workup on you, and maybe they don't check your antibodies, but they look at your free T4 or free T3, free T4. A lot of times I see a down regulation in T3, and then I put hidden antibodies because no one really ever tends to check those unless you're going through a service like this. So, um, the thyroid hormone labs appear normal, yet the body struggles to convert T4 to T3, leading to symptoms requiring attention and intervention. I'm going to get into some of those specific systems that actually help with the conversion of thyroid hormone. I don't think I've ever really talked about that on a call. So I wanted to at least explain some of that. So the physiology with thyroid hormone, we've talked about this, but never went in depth on the deadenose enzymes. So inactive T4 is a precursor hormone. So your thyroid gland makes about 80% T4. And I think of it like raw material or aggregate hormone that doesn't bind to receptors. It requires the conversion of T3 to become effective. Making understanding this process, it's important to understand that. So active T3, it's the hormone that binds to receptors. It regulates metabolism, energy levels. Um, its balance is vital for overall health, emphasizing on the proper conversion of T4 into T3. How does that happen? Deadenose enzymes cause that. So you have three different deadenose enzymes. Uh, one, two, and three, they all play they play a role in the conversion of T4 and T3, um, regulating hormone balance and understanding their function. And we don't have a way of looking at deadenose enzymes specifically in labs. So, um, the way I personally look at this is looking at a GI map, looking at cortisol testing. You could look at nutrient, like a blood spot nutrient profile, and then looking at active hormones. And that can give you an idea of potentially what's going on with deadenose enzymes. Um, and then I like this little graph. I pulled this. So you have D1, D2, and D3. And D1 is going to be mainly in the liver, kidneys, and at the thyroid gland. A lot of times we talk a lot about supporting the liver or supporting the thyroid and giving it cofactors. Your kidneys are also going to play a big role in that. And then substrates, you can see kind of here on this diagram, you have T4. It can convert into reverse T3 or into T3. You also have T2, which is a less potent substrate of thyroid hormone. Um, you have D2, and you can see that this is going to be more in the brain, heart, and muscle. So D1 and D2 are going to be, I think, the most important from symptom management. We think about brain fog. We think about getting adequate thyroid hormone to muscles and heart. Thyroid's going to help with muscle contraction. It's going to give you a normal heart rate. Something I also see a lot of times with hypothyroidism is very low heart rate and hypometabolism. Um, and then D3 is going to have a lot more of this T4 to reverse T3 enzymatic activity. So, layman's terms, when you see a high reverse T3, a lot of times that D3 is upregulated, and that's due to chronic stress is a piece of that, and we'll cover that. So enzymatic function and impact, stress and inflammation elevate this diagnose three while reducing these other two. And this is where we would look at a reverse T3 if we're trying to put things together. So leading to lower free T3 and elevated reverse T3, disrupting overall thyroid hormones balance and health. Um, so again, I wish I could get in and look at like at a cellular level to see all these things. We don't have the capabilities, someone may, but you can use other lab testing to at least get an idea of what's going on. Um, so organ roles, so you have the liver, and that's going to convert about 60% of your T4 to T3. So we talk a lot about supporting the liver and in its role. Well, the liver and the gut are going to be interconnected. So we can see that the gut absorbs T4 effectively, producing local T3 for barrier repair. A lot of times with low thyroid function, we see a lot of constipation and GI issues that arise from hypothyroidism or Hashimoto's. That's a piece of it. We see like dysbiotic bacteria and other things playing a role there, but a lot of times I see issues with motility and elimination. So the gut's going to play a role in that. And then the kidneys are another piece. Kidneys will um, start to downregulate and your filtration becomes abnormal. And that's going to cause issues with maintaining circulating levels of T3 and removal of inactive reverse T3. So I've actually worked with a couple clients here on this call and worked on increasing their EGFR and improving renal function. That simultaneously, they also had hypothyroidism. So again, all of this stuff is interconnected. And, being able to address these things is going to be super helpful for symptom resolution instead of just putting a drug in and hoping that thyroid medication carries the brunt. We really want to support these organs because it's also going to be crucial in healing. We don't want to just mask with drugs. Um, so organs going to play a really big role. So if your coach tells you you want to work on your liver, there's a reason why. We're not just saying it. Um, so liver support and all the coaches could probably go way further in depth on this, but these are just some of the things I talk about. Is like I can't say that word, so I say brassica family. Your cruciferous vegetables, broccoli, Brussels, kale. If you can digest it, I know not everybody can. You could also take DIM or sulforaphane. Those are going to enhance detoxification, help with liver function. Taurine is just one here. There's a bunch of other things. You could use TUDCA. You could use sunflower lecithin. There's a bunch of different things that help with bile production. Choline is also going to be vital in there. Um, Coaches, do y'all have any specific input on like things you like for liver? Outside of these three things, you're more than welcome to chime in. I'm gonna drink a sip of water.
You hit a lot of them. Castor oil packs are good. A lot of the herbs, bitter herbs, you can take for the liver. And obviously just removing things is really helpful for the liver. So all your white flour products, white sugar, alcohol, um, trying to reduce as much over-the-counter medications as possible. Those are really damaging for the liver if you can. And then doing, well, the most extreme one is the olive oil cleanse. That one's always really powerful for getting out liver stones. But again, it's something that, you want to do. Make sure you're in the right position to do it. But I think you hit a lot of them, honestly.
Thank you. Yeah, I don't have as much experience with bitters, but I just started playing with them when I did my detox, and I think that they are definitely great adjunct therapies or adjunct treatments you could add in there.
Oh,
Um,
and herbal teas. I'll throw that in there too. Dandelion tea. I didn't really think there was a lot of power in herbal teas, but now that I've dabbled in them a lot more, I'm a believer. It doesn't take much. Your body's so sensitive. So really they don't underestimate the power of something little. It's a big effect.
I like that you hit on elimination. I think a lot of times I just assume people are here and they've already eliminated those things, and that's a mistake of mine. If we there's so much groundwork that we have if we haven't removed any of the unnecessary toxins and food in our diet. If we're doing that before trying to support the liver, there's really no point. So yeah, I'd say that elimination piece is vital for sure. You want to do that before even looking at these other pieces. Let's see. So gut, thyroid, um, dysbiosis can hinder thyroid absorption, leaky gut. Medication interference is another interesting piece. So I see a lot of women coming in on like proton pump inhibitors for heartburn. Those stop you from absorbing all vitamins and minerals. So if you take yeah, like a common list of medication I see for both men and women is like they're on levothyroxine and then they're on omeprazole. And if you're using like the PPI and the thyroid medication around the same time, you're not going to be able to absorb that thyroid medication. You're not going to absorb calcium or iron or vitamin D. There's just so many things that those proton pump inhibitors cause issues with. Um, yeah, you're on the PPI forever. I think PPIs are supposed to be like short-term treatments, but we just continue to like along that process of like you just stay on them for eternity. Um, they probably have some utility. They do for sure for short-term stuff. I'm not a huge proponent of PPIs though. I think there's usually another way to address those things. Um,
I was
yeah,
gonna say not anymore. I was on it for a long time, and I have like everything that you're saying here. I'm like nodding. I had all of these, so keep going.
yeah, it's crazy. And I
Yeah.
think a lot of people do. Those are two very commonly prescribed medications. Like that's usually on the list of unhealthy people or people who are not well, is like they have that PPI and then they could be on levothyroxine or a statin. And it's just there's other ways you can potentially do things.
Mhm.
Um, so yeah, I think gut's going to play a big role in that, the medication, and then the adenosine expression in the gut for thyroid hormone production is important. So we always will talk about it, kind of working through these different systems. And if you need HRT, that's great. I take thyroid replacement. I know some people in this call do, and but we don't want to just take that and not do any of these other pieces. It's really not going to have the same effects. Um, let's see, what else do we have here? And then the kidney function is another piece. Kidneys maintain circulating levels of T3. I think of that like a reservoir. It goes in and it filtrates and then it sends some back out. But it's going to go in and filtrate excess reverse T3. Stress can drive up issues with filtration. You have your adrenal glands that sit on top of the kidneys that can imbalance electrolytes. It can imbalance thyroid hormones. All these things are intertwined. Minimal things here, optimal hydration, protein intake, adequate protein intake. I think a lot of times people misconstrue that protein can cause issues to the kidneys. I'm not a believer of that myself. There's conflicting data on both sides. Is it that eating enough protein supports a healthy EGFR, and then some camps will say that you don't need protein. That's another topic for another day. The kidneys are also going to play a big role, and we'll talk a lot about liver and gut, but I just wanted to highlight the kidneys. I would say most people coming in here aren't going to have some sort of impairment of kidneys, but it does pop up occasionally with certain clients. And then stress. This is a big piece for sure. So if you're looking at cortisol, cytokines, so elevations in cortisol levels in inflammatory cytokines. So you have different ones, interleukin 6, TNF alpha. They will downregulate that deadenose expression 1 and 2. So we talk a lot about the impact of reverse T3 and stress response lowering thyroid hormone. This is that cascade that potentially could happen. Again, this is more us putting those pieces together. We can test your IL-6 and TNF alpha, but those are very, very expensive. A lot of times we will take some of those other markers and get an assumption of potentially what's going on with your body. And cofactors, these are some of them. We talk a lot about selenium and zinc, iron, tyrosine, um, vitamin D. There's several cofactors, but these are things that we also will just pay attention to and supplement or eat into or add into our diet from food. But looking at those systems, these cofactors are essential. So, kind of top to bottom where thyroid's made, and then potentially cofactors that help with those processes. And then medication options, I just like want to highlight this. Obviously, these aren't guidelines for dosing or anything like that. Is a common medication is levothyroxine. We see that quite a bit. You will see levothyroxine given. Some of our clientele will come in working with a functional doctor or somewhere else, and they may be doing a dual therapy. My preferred is that sustained release levothyroxine because you don't have to have multi-dosing throughout the day. It's going to have a longer half-life, and it's going to be very similar to what your body naturally produces versus taking levothyroxine and then pulsing fast-acting cytomel or levothyroxine throughout the day. Sometimes that can cause issues with heart rates and jitters and anxiety. So that's just my preferred way. I didn't have desiccated thyroid on here, but that's another treatment we'll see a lot of patients use. It's a pig glandular, both T4 and T3. And then I wanted to at least put this in here if anybody wants this document, because I think a lot of times people think that it's crazy to take T3 therapy. And this study is, I believe, from 1989, and it talks about hypothyroidism with monotherapy of levothyroxine. And what they're saying here in this study is that, and it's small groups, I think it's like 4,000 people were looked at in the study. It's not huge. So you have trials of 1,000, maybe it's just 1,000 people. But they're saying that, prescribing parameters usually is levothyroxine is monotherapy for a year. And if patients are not relieved of symptoms, so for patients who remain symptomatic on levothyroxine therapy, clinical guidelines on a trial basis therapy, they talk about taking T4 and T3, reducing some of the T4 and then adding in T3. Um, And they're basically saying that there has been no associations of adverse drug reactions and um, mortality and morbidity risk due to cardiovascular disease, arterial fibrillation, and fractures. Those things weren't really seen because you're not taking those up to super physiological limits. So, I think this is just interesting to look at. It's like this data is like 36 years old that people realize that this was a good treatment, but a lot of practitioners don't do that. They just give the monotherapy. So, um, this goes into both desiccated and levothyroxine. I could drop this in the chat if anybody wants it, but I just think it's good to know it's not just random advice that providers through First Optimal are recommending, or anybody who works with me, knows that a lot of this stuff has been well studied. And then I want to hit on some other things. So some of our patients were using or are using low-dose naltrexone for Hashimoto's. So naltrexone is given at higher doses for uh, addiction. It could be alcoholism or
Oh,
opiates,
you.
but it's given at lower dosings to modulate immune system. Um, so action, it temporarily receptor blocks. So it blocks opioid receptors in the brain, which helps with higher endorphins. It also balances immunity. So it lowers inflammation and can lower TPO and thyroid globulin antibodies. What I see a lot of times is it will help with fatigue, um, reduce brain fog. It does seem to help with sleep with some people. Dosing, you will see, these aren't recommendations, but this is what a lot of clinics will do is titration from half a milligram up to 4.5 milligrams. Vivid dreams, mild sleep issues, it depends on the individual. I take 1.5 milligrams of low-dose naltrexone. I have for years. I really like it. I do think that it helps keep my inflammation lower. I have some low-grade autoimmunity-like symptoms. Um, but low-dose naltrexone and thyroid, it can help improve the immune-based issues, reduce T cells and antibodies, supports the mitochondria, lowers the interleukin 6 and TNF alpha, and thyroid aids in serotonin, LDN lifts endorphins. From an energy standpoint, thyroid improves ATP, LDN cuts inflammation, fatigue. So I have seen it work for some people. Again, it is just a medication. It doesn't work for everybody. I've also seen people have negative reactions to it. So this is where medicine becomes very customized to individuals and what they need. Um, I think that was the last slide. Yep. Does anybody have any specific questions for me or for the group? I know that was more of educational information, but I just think it's good to kind of understand some of these processes. I know somebody will watch this and I will speak with that individual and they'll be happy that I did that. So, um, yeah, I'm happy to open it up and see if any clients have any questions or coaches.
So, Justin, to test for Hashimoto's, it's thyroid antibodies versus just I'm on the thyroid replacement, still struggling to lose weight. Would it change the treatment plan for me if I was diagnosed with Hashimoto's?
Not necessarily. If you're using a compounded T4 and T3, that's going to be like the standard of care for most individuals with Hashimoto's. Now, if you had antibodies present, I think that's like where you would probably want to get more hyper specific on food sensitivities, allergies, stress management, immune-based stuff, um, low dose naltrexone for some individuals, not everybody. I think that that's where those things could potentially shine. What I do see a lot of times with Hashimoto's is um, there can be inflammation causing water retention, sore joints, general fatigue. So there may be some other things from like a lifestyle, nutritional, maybe even pharmaceutical approach that could benefit that individual. But for hypothyroidism and Hashimoto's, most patients are going to take a compounded thyroid medication.
Thank you.
Hmm.
I'm just gonna throw this out there. I had put in the Facebook, private Facebook group, the connection between parasite infection and Hashimoto's, and I think it's a very fascinating conversation. It's a rabbit hole, I think, maybe for a lot of people because it's not widely discussed, I think, in the medical community correlating to underlying toxins and infections. But if any of you have time and you have Hashimoto's or you're dealing with it, I think it's definitely worth a listen from two different doctors that deal specifically with thyroid issues and
Yeah.
have dealt with it in their own personal life. So it's very
Can
fascinating.
Do you have any like brief things off the top of your head that you can share with the group? I'm interested in that for sure.
Uh, no, I think you should just go listen to it. It's just something that I don't know. I don't know what to say other than when I heard it, I was like, that makes sense. Doesn't mean it's for everyone and everyone's gonna say as it makes sense to them, but I think it's definitely something to just open up and hear one time and then put it on the back burner if you're not sure about it. But it does make for great conversation when you're connecting the root cause of what happens to us in autoimmunity. So,
Yeah.
and I'm just a huge root cause person. So I'm always going to dig deeper and be like, but why? What was the start? And how did that happen? And, over time, why does it get worse? And I think I've just done a lot of band-aiding in my life. So I kind of am over with band-aiding. And that's why I love their conversation so much because it is about root cause. So,
Yeah, I think that's interesting. I'll have to check that out. I think
mhm.
the cool thing with Hashimoto's, or not necessarily cool, but interesting is, I mean, it impacts the thyroid, but is it a thyroid-based issue? Your thyroid is under attack, but is it necessarily a root cause to the thyroid, or is there all these other systems that are kind of heightening that fire, and your thyroid is unfortunately the target of that? That's kind of my assumption of it. And then hypothyroidism is a piece of it, but it doesn't originate from hypothyroidism, in my personal opinion. I think it's all of those other systems that play a role in that.
Yeah, I would agree with that 110%. I don't think it's ever just the thyroid. It's always the thyroid being pulled under by um, toxic loads. And over time, the thyroid becomes worse. And I think that's where the whole conversation around cysts and nodules and why things grow where they grow is very fascinating to me and what is causing them to grow and what are they. It's a fascinating thing since I deal with cyst growing. Some people have, small nodules on their thyroid and cyst growing, but why? Why does the body want to put it right there and what is causing it to grow? So I think the body is fascinating and very smart and there's very specific reasons why things happen. But yeah, start somewhere and then I think to your point, Justin, it cascades over time because we haven't really learned how to detox well in a way. So I think that's why the conversation like as people get older, it's normal. That happens. You should expect this. You're 40s and 50s and 60s now, but really maybe we're missing the point of we haven't done enough work around cleaning up and then pulling out. We talk a lot about cleaning up, but pulling out and actually going through the tough stuff to detox is a little bit tougher and it's not so easy. So I think if we could get better at that, then that would be very helpful to minimize a lot of the symptoms over time, not necessarily overnight, over time.
Yeah, no, I love that. That's great. Ashley, do you have anything that you would want to chime in about like autoimmunity, Hashimoto's, hypothyroidism from like a GI aspect?
I mean, good question. I mean, y'all hear me say this all the time, but um, the gut connects everything. Um, um, but I don't know that I have anything like super specific, other than a lot of what you're saying, just in terms of, the GI has such a good impact on liver health and detoxification, and just that all of those pathways working well.
just make a big difference for, I guess, overall balance, right? Um, I mean, in terms of Hashimoto's, I mean, I think a big piece of it is just really that like gut immunity connection, basically, right? Because I say this a lot, but we get, 70-80% of our immune system from the gut. So, I mean, it's just like any other homeostasis in the body. When we aren't digesting our food well, we're not getting all the vitamins and minerals we need for everything else to work well, for our thyroid to work well too, for that, but also just, immune activation. So a lot of times, some of the things we talk about with GI map is certain bacteria are like autoimmune related, right? So like when you have imbalance in the gut, that can trigger immune activation. And so that can trigger, so then more likely to have your immune system attacking itself, right? Such as the thyroid gland. Um, and so, that having dysbiosis and imbalance can, I mean, there's definitely a chicken and an egg here thing, but can trigger more inflammation and consequently can trigger more autoimmunity. Um, and so I think that the other piece of that is just inflammation, right? Inflammation in there um, just aggravates autoimmunity in and of itself, right? With regulation of T cells and everything that's going to help with that. And just obviously bacteria imbalance can imbalance your immune system that can correlate with that. So I mean, I think that's the biggest thing. Just and then again, just I mentioned this a second ago, but like just when we're not absorbing nutrients, then the things that are going to help support thyroid, that we think basics, right? Like iodine and selenium and whatever. If we're not able to absorb that and balance those, then we're, it's just less homeostasis and less ability to balance out that. So your selenium and zinc and magnesium and, all of that. Yeah, I think that's the biggest things that I can think of.
Do you ever see somebody with autoimmunity or Hashimoto's have very good inflammation and great numbers in the gut? And the reason I ask that is I tend to see
No.
a lot of trends, and that's where I'm going with
Well,
this.
and that's kind of what I was saying. There's like a chicken and an egg thing. It's hard to know what came first, right? It's hard to know that, but I would say dysbiosis can trigger I'll just use Hashimoto's, can trigger Hashimoto's, but also they just go hand in hand. So like like an imbalance. So I would agree. That's why that's why we call the gut the second brain, right? And I tell everybody when they hop on a call, I'm like, so I'm not saying this is going to solve everything, but it's a really good start. And so I know again that's my area, but I'm like always start with the gut because at least it could also tell us I don't know whether you need more detoxification and whether you need your liver and so yeah, I mean that's if we can balance out the gut, I think you have a much better chance of fighting everything else.
Yeah, no, I think that's great. Um, does anybody have any other questions or any more input from coaches? We have a couple minutes here, so I wanted to make sure I didn't stop anybody from saying anything. But yeah, I thought this was great. I felt like we covered a lot of information here.
I have a quick question, Justin. If you're on thyroid medication, like I'm getting ready to have my annual physical, would it be worthwhile to to request antibody testing
I would
on
say
my thyroid?
you've
Or
not.
would it be inaccurate because I've been supplementing?
No, I would say there's lots of people who take thyroid medication who still have elevations in their antibodies. I would say that if you haven't had them tested, I would most definitely test them. And off the top of my head, I can't remember with your specific panel if those were included. But you could go back and look and see if those antibodies were specifically tested. But I would say that it's worthwhile at least to like cross them off and get an idea. Now, the thing is with antibodies, they can ebb and flow. So sometimes I see them where they're not elevated on people and like, hey, these look actually really good. And they're like, oh, well, look at these labs from 6 months ago. And they're like in the hundreds. I'm like, whoa. So I think there's a lot of things that can influence that. So just, you know, something to think about is if you have them done once and they're not elevated, but you have symptoms that kind of mimic or mirror what's going on, you probably want to look at them a couple times. Um, Maybe after you're sick or something would be a good time. I've seen people in 2020 when there was all kinds of weird viruses going around, have never have elevations in thyroid TPOs or thyroid globulin antibodies, and then all of a sudden have huge spikes in those from getting some sort of weird virus. So it would be
Right.
something to look at a couple times, in my opinion, specifically if you think you're dealing with those types of symptoms.
Okay. And then I was just wondering for the group of us, I guess it's individual specific. We go into, primary care where all of our labs are going to be covered. Do you have like a template of like labs you recommend? Normally they just do like, a chemistry panel, a CBC, an A1C, a lipid panel. Is there anything else you would recommend requesting?
Yeah, I would recommend what I would say is I could look at your initial stuff because I reviewed your labs. We probably have a rec form that we sent you initially. I would give
Yeah.
those to my PCP and be like, hey, I know this isn't an accurate rec form, but how much of this stuff can you test for me? And then just
Okay.
show them that list of things. And he or she may be able to do all of them, or he or she may say, hey, I can do three of them, and then the other 30 are not covered by insurance. And the thing you
Okay.
want to be considered to consider is they may test all of those things for you, and then they may send you a bill for like $800. So
Yeah.
I
Okay.
am always very hesitant because I've done that one time. My PCP said, "Yeah, I could check your T3 and your free testosterone," and then I got a bill, and it was more money than what I would have paid for that whole panel out of pocket. So
Right.
I
Right.
would be cautious with that.
Okay. Thank you.
Absolutely. Andrea, so happy to hear that LDN helps my thyroid. Not sure how much it helps with. Uh, so you're having issues with your autonomic nervous system. So is this with specifically with um, heart rate, blood pressure? Is this tied into your POTS? Is what you're asking here? Um, side subject here, different topic. Let me see. Yes. I'm not sure if it's going to have any impact on blood pressure or anything like that. I have not seen enough data on that. What I see a lot of times is mast cell activation, histamines, other things causing issues with POTS. I don't know if LDN will help with that. I know it will lower inflammation, but I don't want to say yes, I've seen that because I've never seen that tie in together. Um, Different topic, how urgent is it to treat high prolactin? I can't take the medication at the moment as another medication opposes it, and it's the longest process to taper off. So I'm assuming they were wanting you to look at um, uh, cabergoline or what is it? What is the other name brand for it? It's basically dopamine agonist is what they give for hyperprolactinemia. And if you're using some sort of SSRI, SNRI, you may not be able to take those medication together. If you haven't had a CT scan of the pituitary gland to see if you have an adenoma, so I worked with a doctor at a different HRT clinic for a long time, and she would do send out referrals for that scan. Really, the issue is if you do have an adenoma growing in your pituitary gland. Again, I'm not an even any doctor of any sort, but the way she explained this to me is
Mhm.
that you have basically the there's a stem that controls your vision, and if you have something growing on that pituitary gland, it can basically come down and cause issues with your vision. As that adenoma grows, it will hang that pituitary gland further. And so blindness or vision disturbances are things that you could potentially be worried about. Hyperprolactinemia may cause some issues with your thyroid function, but I think vision is the biggest thing. So it depends on do you have an adenoma? How big is it? How quick is it growing? And then that would kind of, in my opinion, where I'd base off of like, hey,
Mhm.
do I want to treat this?
Yeah, so because kind of my PCP was kind of like, yeah, we can just give you the what's the medication you just mentioned?
Cabergoline.
Yeah, and I was like, he's my new PCP. So I was like, I can't because I'm on medication that or antagonists or agonists, I'm not sure. And he was like, oh, yeah, I'm not sure what to do. So I decided I'm going to ask you. And I did also a little bit of research and um yeah, it's probably an MRI is probably the wisest. Yeah,
See how big it is, and if it, they probably want to track that over time, um, that MRI to see if that is growing, and if it is, then you may need a medication, or it may be something that's not growing. The thing is, those pituitary adenomas or adrenal adenomas, I've seen those on someone else, is that the reason they're never caught is because no one ever looks at prolactin or DHEA
yeah,
sulfate. They're like, oh, it's such a rarity. And I'm like, is it though? No one ever checks those markers. So they're more common than you think. I would say in the
yeah. I
HRT.
have seen, yeah, I have hypergalacturia or galacturia, so that's how I figured.
Yeah, and that all those things are going to tie into thyroid dysregulation, inovulation, prolactin will skew a bunch of those things, and that's why we screen for
Mm,
prolactin on our panels. Sometimes it's really elevated, and that's causing all of those other issues.
mm, mm. It used to be high already a couple of years ago due to the medication, but then I decreased the medication by a lot. And now all of a sudden it's much higher than it even used to be on the higher dose of medication, which I say would indicate that there is maybe something growing, but I don't know. Yeah.
Yeah, they're usually benign, but you definitely want to get it
Mm,
looked at. The biggest thing I would say is your vision would be the thing I would be most concerned.
yeah. Yeah. Okay. So I'll check that out. Yeah. Thanks for
Yeah,
the tip.
absolutely. All right. Well, if we don't have any more questions, I appreciate everybody's input today. Thanks for those who hopped in and watched with us. And I'll get this over so a replay is available. And I hope everybody has a great rest of their week. Thank you.
Bye, take care.
Bye.